So now let's get started. So our first speaker is Dr. Jonathan Irish. And Dr. Irish graduated with his MD degree from the University of Toronto. He completed residency training at UCLA and at the University of Toronto. He completed the American Head and Neck Society Fellowship in Head and Neck Oncology and joined the staff of the University Health Network in 1992. Dr. Irish is an international leader on quality improvement in cancer surgery and access to care improvements in healthcare systems, and a national leader on the development of novel approaches, development of navigation and tracking systems, and the development of robotics for cancer surgery. So please welcome Dr. Irish.
I'm just going to mic up here because I tend to move around. I want to thank Michael and the rest of the organizers for inviting me today. I'll bring up the other talk first. The Georgian Bay, we have the Georgian College, we have Collingwood Hospital, ROMP. I love that, by the way. When you invited me for a romp, I didn't know what that exactly was going to be, and then I read the rest of the email and it was safe. So thank you for inviting me. There's lots of stakeholders here today. We have healthcare providers, primary care providers, specialists, we have patients, we have allied health, nursing. We all have a stake in this, in care for our patients, and I will be speaking about cancer care. And what I'd like to reflect on over the course of the next 45 minutes, and I'm looking at the time and I'll be very careful to stay on time, is what I'd like to reflect on is the past, the present, and hopefully I'll get to the future and some of the research that we're doing with it. You have Dr. Tak Mak here as well, and other fantastic speakers today. Medical oncologists from RVH talking about guided therapeutics and novel therapeutics and biologicals, and I'm sure immunotherapy as well. All cool and innovative new treatments that we have for our patients. But I'm going to reflect back. I'm going to reflect back on my experience over the last 15 years at Cancer Care Ontario. And at the end of the day, what I really love talking about is to Ontario people. I get invited internationally and nationally to talk about our story. And quite frankly, Ontario has become known for turning around the cancer system to provide good care. And we're not there yet. We're not perfect, but we're certainly good. And I would say in many areas, we're great. And what I'd like to do is reflect back, think back to 2002. These were the headlines. We were making global impact across the world for all of the wrong reasons. Access to care, wait times for treatment was egregious. We were hearing from our patients and hearing from our providers that people were waiting too long, not just for cancer care, but for many other services. Are we perfect today? No. You only have to look at a poster down the hall on satisfaction. Dr. Lisi, you're an author just about on all the posters, by the way. But if you look at satisfaction with access, this center's 82%. Yeah, not bad, not great, but very good. But I expect that if you took that same survey 15 years ago, you were going to be very poor. And in fact, the New York Times, the Toronto Star, and across the world, we were making headlines for all of the wrong reasons. And yet, egregiously, when the government went to the agency that was responsible for care of cancer patients in the province, we could answer the questions with regards to radiation treatment, to therapy, to systemic therapy or medical therapy, but we had no accepted definitions of what an acceptable wait time was, what a target was. We had no accepted benchmarks. We had no knowledge of cancer surgery activity, no knowledge at all of wait lists in the province, and no link, most importantly, to quality of care. And that was just 15 or 16 years ago. And so really the mandate of our program, since I've joined Cancer Care Ontario in 2003 and been responsible for the cancer surgery program for 10 years, is our mission has been twofold. Improve access to care and improve access to quality care. There's no use in improving access to poor care or average care, but good, high-quality care throughout the province, no matter where you receive it. At Collingwood General, at Timmins, at University Health Network where I live, or Princess Margaret Hospital where I practice. I said I pretty well live there. The care should be excellent no matter where you receive that care. And in fact, if you look at how access to care has improved over the province, if you look back 15 years, we were functioning at about 40 to 50% of hitting those targets. We established targets, first of all. We established a wait time information system that links every hospital in the province. All 65,000 patients who receive cancer surgery in the province have monitored wait times, and we report them monthly. You can go on the website and see what the current wait time is for care, not just in cancer surgery, but across many other surgical services. We have benchmarks, we have targets, we report them transparently to the public, to you, to our stakeholders, to government. Because the fact of the matter is we have to be responsible. We have to be accountable for the care, access to care, and access to high quality care. And although we started with the most challenging areas, CT, MR, joint replacement, knee, and hip replacement, you can't see that very well, I apologize, and cancer surgery. And by the way, the purple describes the percentage performance. So the larger the purple is in this graph, the better you're performing. And you can see that we report the service areas for cataracts, hip replacement, joint replacement. And over time, of course, we've expanded the services that we report to general surgery, to other areas as we expand. So not only are you seeing that we expand the services that we're reporting, all of them now for surgery, but we're also essentially improved over time. So the purple, you can see, has expanded. Our performance has improved. The notch here is MRI scans. MRI scans, so this is a story in and of itself. So we can give more OR time, we can monitor, we can improve processes, as you have done quite clearly here in Collingwood with regards to access to care, if you look at the poster and so on. But there are some elements that we need to do better on, not just on providing more services, more money, more OR time, more surgeons, but there's an element here of accountability around appropriateness. So what did we do with the MRI scan problem in the province? Well, we informed the province that clearly there was an access to care issue. We need to run MRIs 7/24, and we built 9 MRI scans throughout the province. Our performance went from 28% to 31%. Millions, tens of millions of dollars spent operationally to run the MRI scans and to build new MRI scans. What was the problem? The problem was that most MRI scans in the province are performed for 2 reasons. headache, and low back pain. And the yield for the MRI scan result, less than 1%. So patients were receiving a lot of MRI scans. They had access, still poor access, but for all of the wrong reasons. So our job there was to work with our radiology community and our primary care practice community, which we have done, to educate around appropriateness of ordering tests as well. So it's not all about resource, it's all about choosing wisely. And you'll hear, as many of you in the medical part of this audience have heard about choosing wisely about the tests that we perform, the antibiotics that we order, etc., etc. We have to be partners, we have to be part and partners of the solution, because sometimes we create the problem. And not only do we report it systemically, but this is my personal report card. It's intentionally written so you can't read it. Small letters and fuzzy. But the fact of the matter is that every quarter, every 3 months, I get a personal report card sent by me to me, but sent to all 3,500 surgeons in the province from me, from my Access to Care portfolio, to see so that you know how you're performing. It doesn't go to your vice president of medical staff. It doesn't go to the chief of your service. It isn't meant to be punitive. It's meant to say, here is how you're doing. Here is how your peers are doing in your hospital in comparison to you. Here are how your peers are doing in your region in comparison to you. And here are your peers in your province doing in comparison to you. How can you do better? If you need to improve, call us. We'd like to help. And you know what? When you get personal data, on access to care and access to quality care, how can you improve if you don't know how you're doing? How can you improve if you don't know how others are doing? And how can you improve if you don't have a target to improve to? What's the standard? It isn't meant to be punitive. That's why we don't spread it around. That's why we don't deliver it to the chief of the service or to the chief of medical affairs for the hospital. We deliver it to you because, quite frankly, at least on the surgical domain, the most competitive animal in the medical kingdom is the surgeon, because he or she wants to do better. There is no doctor that I have met, medical, radiation, or surgeon, or for that matter, anyone in healthcare who practices from nursing and allied health, etc., who wants to give average or below average care. I've never met that person. Sure, we all have bad days. We all have bad days. But we know that at the end of the day, we want to deliver good care. We want to deliver the best care possible with the resources that we have. And so the access to care and access to quality care has been all about leveraging performance data, sharing that data, and working with our communities of practice, locally, regionally, obviously, provincially, to improve. And so Cancer Care Ontario has been all about that, has been all about data, has been all about collecting data, working with experts, medical experts in our community. I just got off a phone call at 7 o'clock to 8 o'clock this morning. I was sitting in the doctor's lounge with a community of practice of head and neck surgeons. I'm a head and neck surgeon, but just by accident, it was head and neck surgery this morning, but yesterday it was gynae. Talking to experts throughout the province on quality indicators that we want to monitor for this coming year in the province. For gynae yesterday, head and neck today, and tomorrow it'll be colorectal cancer surgery. It's not me. It's not Cancer Care Ontario who established these benchmarks or standards. It's our medical community. And by the way, we have patients sitting on our our communities as well. And so this concept of current state, understanding the current incidence and mortality and survival and quality performance now, understanding current state, and understanding where we want to be in an ideal state is what Cancer Care Ontario has been all about. We collect data. We establish clinical guidelines or indicators, targets. We then disseminate knowledge transfer to our communities on what the targets should be. And then we performance manage them. We share the performance regionally, locally, and provincially. How are you doing? How are you doing in your care compared to your peers? You, your hospital, your region, in comparison to each other. Not in a punitive way, but how can we do better? How can you do better? How can we do better if we don't know how we're doing now and what the target is and where we should be going? What is our ideal state? And this is just a partial list of the things that we've done over the last 10 years in breast and colorectal and prostate and hepatobiliary or pancreatic surgery and thoracic surgery, rectal, et cetera, et cetera, et cetera. We've established guidelines. We've established targets. We've established standards. The other area, and it's important for this group particularly, is to understand that there are two types of cancers from a system management perspective. There's the cancer where we need to move quality to the patient, where the cancer is so common that your care in Collingwood, at Royal Vic, Timmins, Thunder Bay Regional, Windsor Hotel Dieu, UHN should be the same. Colorectal, prostate, breast, common cancers, where the centers of experience, because of the volume of care, can be accrued at many centers. So the question, or the issue is to ensure that the quality of care is the same no matter where you get your care. And then the other type of cancer is where we need to move the patient to quality. I used to use the word centers of excellence. It's actually centers of experience, where it is the team working together, the nurse, allied health, speech-language pathology, surgeon, radiation oncologist, medical oncologist, who have experience in an area where the complexity of the cancer, the interdisciplinary nature of the cancer, the rarity of the cancer necessitates care in centers where we have a volume of care. In 1990, 65 hospitals in this province did thoracic surgery. Now, today, it's 15. There were surgeons doing 3 or 4 pneumonectomies a year. Now, don't get me wrong, I'm sure they did it well. But the fact of the matter is that when you're doing 3 or 4 things a year, it's probably not ideal. And so the concept of balancing, moving the patients to centers of experience, and getting care closer to home, which is actually the mission of Cancer Care Ontario, needs to be a balance. But I think we've struck that balance. And so essentially over the course of the last 10 years, we've regionalized in 5 areas, which I'll talk about. But there's a story. So let's talk about prostate cancer, which is a cancer where we would see most patients receiving care closer to home. So the majority, if you had your cancer removed, or your prostate cancer removed in, let's say 2009, the margin positive rate in the province for T2 prostate cancer would be 40%. That means your surgeon left behind cancer 40% of the time. Now, I come from a cancer, I treat a cancer, where that would be egregious, unacceptable. Quite frankly, I'd probably not be practicing. Prostate cancer is different. We looked at the data, we said that's current state. We brought in our prostate surgeons, our radiation oncologists, pathologists, other stakeholders, and said, current state. We looked at benchmarks throughout the world, and we said, typically, most centers in the world are establishing targets around 15 to 20%. Is this current state acceptable? What were the reasons? There was lots of reasons. There were reasons around pathology interpretation. There are reasons around dissection, surgical dissection, leaving not necessarily cancer behind, but interpretation of the results. We had 2 workshops, and then we had a knowledge transfer webinar throughout the province. And as you can see, within 6 months, within 2 quarters in this province, our margin rates went from what I thought was egregious to world standard. And currently, we continue to monitor this, and we're between 15 and 20% in the province. And this is something we report publicly. We report it publicly. And so that is an example whereby surgeons, pathologists, and others were saying, we can do better. I can do better. This is how we can do better together. And this is something that has been sustained over time. On the other hand, there's the story about, which is less common, about moving a smaller number of patients to centers of experience because of the rarity or high complexity nature of the cancer. HPV surgery, pancreatic surgery, thoracic surgery, which has 15 centers, sarcoma surgery, which has 3 centers in the province, gynecological oncology centers, which there are 9 centers in the province, including Royal Victoria Hospital, and head and neck, which is the area I practice in which there are 8 centers in the province. And our organizational standards related to describing these centers of excellence or centers of experience describe the training that must be necessary, the facilities and standards and infrastructure, and the volume of care. The volume of care. In other words, the center of experience. And we've changed. And if I was reporting a new drug, and I reported a 5% improvement in survival, I'd be famous. If I reported a 10% survival in pancreatic care, cancer care, I'd be famous. Well, we've done that. Just by organizing our province such that you go, yes, you do have to travel to a center of experience if you have these types of cancers. Your chance of living has improved by 5%. It's gone from a 10% to 5% mortality rate in the case of lung pneumonectomy. Has gone to 14% in a low volume pancreatic cancer center to currently 2% survival or postoperative mortality because you're going to a center of experience. In head and neck cancer, and this is work that we've done, your chance of surviving 5 and 10 years goes up 3% for every 25 cases that are seen by a center. So let's put it in stark terms. If I see 100 cases versus a person who's seeing less than 5 a year, your chance of surviving at 5 and 10 years is 10 to 12% better. That's remarkable. If I had a drug that was 10, and I was reporting in a journal a 10 to 12% improvement in survival, that would be headlines across any medical journal in the world. And we've done it in Ontario by organizing our system. And this is why I get invited, not because I discover new drugs like Dr. Tak Mak or new ways to treat cancer, like you're going to hear today, but because we've organized our system. Yes, we have a ways to go. In other jurisdictions, the United States, Europe, Australia, are adapting or adopting our system of approach that we've developed here in Ontario, and other provinces, by the way, as well. Quality-based procedure funding, which is a new funding approach in the province that was initiated about 4 years ago, has been implemented in the province. It's, I'm not going to get into the details on the funding, because you'd all fall asleep if you haven't fallen asleep already. But the concept of this is to better improve the quality reporting that we're doing. It's quality-based procedure funding. In the first year, all of the hospitals are concentrated on the last word, funding. As we've moved and matured along the process of implementation, we are now concentrating on the most important word, quality. And basically, this approach describes the best practice or care path for each of our patients in our system, the length of stay recommendations, and we develop quality indicators related to this. And we develop indicators, for example, across all breast sites, which we call global or common indicators, the proportion of patients that are reoperated on within 30 days, the proportion of patients that died within 30 or 90 days, participation in multidisciplinary cancer conferences, which are conferences where we bring multiple disciplines together, readmissions, length of stay, as I mentioned already, et cetera, et cetera. And then we develop site-specific indicators. For example, in breasts, the proportion that receive preoperative imaging, mammogram, ultrasound, or MRI scan, or needle biopsy prior to resection, or positive margin rates after resection, or proportion of mastectomy patients that receive reconstruction. Examples of good care. And we have developed 3 or 4 indicators per site in addition to the global indicators which are performed across all of the sites. And what does this do? It creates a surgical quality index, or what I call ski report approach every year. So every year, Dr. Lisi and all of the administrators at the Collingwood Hospital, Royal Victoria Hospital, receive their ski report, surgical quality index report. And it allows our hospitals, our regions, to compare. How are we doing? Why are we not doing well in this area? How can we improve? Why are we doing well in this area? How can we share our experience with other colleagues? Not meant to be punitive. It's meant to say, hey, this is how we're doing. This is how we can improve. And this is an example, and this is data from this region. Collingwood General and Marine Hospital is right there. There's the provincial average. Don't mean to say you're average. You're right at the mean. That's a better way to say it, right? You're right there with good quality care. This would be those who are, this is unplanned visit rate. So this would be patients who come back to the emergency room or have to be readmitted to hospital within 30 days after surgery. And typically it's about 20%. So when I share this, the immediate thing is, 20, let's say you're up here, a hospital's going, we're bad. My surgeon's bad. No. This is about a system. So, if you're an outlier, it might be that you're discharging patients too early. It might be because your nurse navigator or a lack of nurse navigator or your phone call at 24 hours or 48 hours to your patient and they're still having pain And you could have actually done a proactive intervention with pain support rather than coming back to the hospital for pain medications. Maybe that's the solution. Maybe there's a CCAC issue and support issue with your partners in the community. Maybe it's a remote area and they don't have primary care coverage. And so they have to come back to emerge. So it's a function of the system. It's not about necessarily the surgeon or the surgical team. It is a system. And so we need to, when we share data, we need to share it with knowledge of the system. This isn't meant to say, you're bad. It's meant to say, let's look at how you can get better. And this is how we share this data. This is an example of 30-day unplanned visit rates for breast patients without reconstruction. And you can see Collingwood and other Royal Vic and all of the hospitals in your region and all of the hospitals in your province that have this kind of number. You can see the mean here. You can see the upper first standard deviation, the second deviation, and so on. The concept here isn't about what is my data. It's about the fact that we can show performance. Partial thyroidectomy for low-risk thyroid cancer, for example. We can monitor in the province. We can monitor by region, i.e. the concept of appropriateness. So this would be an example of a site-specific quality indicator for thyroidectomy. Our thyroid surgeons chose the partial thyroidectomy for low-risk thyroid cancer as a quality indicator. So the concept here is that these are very detailed amounts of information. And I don't know if this will work, but this was meant to be, no, it's not working, but it's meant to be a short video to demonstrate how you can toggle. You can toggle with the ski report to select the region, to select your hospital, to select the area of your performance, and your data comes up and it compares you against others. What's the message? The message is audit and feedback. The message is accountability. The message is transparency to stakeholders, to citizens, to patients. This is available on our websites. This is available to our hospitals. It's available to our ministry, and it informs us as system managers of where we can work with you, our partners, our stakeholders, to improve, and so on. You know, one of the greatest Canadian physicians said 100 years ago, but he was saying it about teaching at the bedside on one patient. Observe, record, tabulate, communicate. Use your 5 senses. Learn to see, learn to hear, learn to feel, learn to smell. Now, he was saying that about one patient. But in this digital age, where we have global data, where we have big data, where we have performance data, we can still observe, record, tabulate, and of course communicate, not about one patient, but about all of our patients, and improve. And know that by practice alone, that we will become expert. And so, well, it's 100 years old, this quote, it can still apply today. So, data on performance is powerful. Funding, which this all started to solve a wait time issue. We've got $10 million the first year. We got $80 million by year 10. And now my budget is $462 million to fund all of cancer surgery in the province. It wasn't just about funding more surgery to reduce wait times. It was about implementing quality improvement associated with that volume. And developing communities of practice is critical, because quality improvement doesn't occur on University Avenue, where CCO is. It occurs here. It occurs in the pathology bench. It occurs in the operating room. It occurs in the chemo daycare suite. It occurs in the radiation treatment facility. It doesn't occur on University Avenue. So the community of practice is critical. And being a clinical leader in quality improvement is a contact sport. good and bad. You know, it is not easy, I can assure you, and I know that local leaders would mean it has the same issues. But clinical credibility is critical to healthcare reform. So I want to thank you for the first part of the talk. I've got another 10-minute talk, but maybe I should stop for a short amount of questions in the interest of time. I have 12 more minutes, but maybe I can entertain a question or two about this part of the talk. Before I move on to, this was the past and the present, I want to move on to some of the research that we're doing for the future. Any questions? Maybe I'll stop with Emma toggles to my next part of my talk. No questions? Probably bored everyone and put you to sleep. You got TACMAC and... Okay. So let's look ahead to the future. Looking ahead, the vision of surgery in 2020. And this is research that I'm doing at the Princess Margaret. I'm taking off my Cancer Care Ontario hat and I'm wearing a head and neck surgeon hat. We were very lucky, my team was very lucky to receive a $7 million Terry Fox Expanding Horizons grant for new research that we're doing in the area of cancer treatment. And it's the whole concept here that the knife, the eyes, and the hand of the future surgeon will be very different, are in fact very different than they are today. I mean, I think back 27 years from when I first practiced, we had films, and we put them on a film box. And we know now, in fact, we have digital. And in fact, we most often use now not just 3 dimensions, but 4 dimensions, because we know that cancer changes in size over time. We know during radiation treatment, the tumor will change during the course of radiation. During chemotherapy, the tumor will change during chemotherapeutic treatment. And in surgery, unlike radiation, which might occur over days or weeks, or medical treatment over days or weeks, in surgery, the tumor might change over minutes, because as we access the tumor, we are altering anatomy around the tumor. We are altering the tumor. And so in the past, we've always relied on imaging that we took yesterday or 5 days ago, but the need for real-time on-the-table imaging is absolutely critical. And so this concept of the hands of the future surgeon, for example, now we have robots. And there's this concept, of course, that we just put the patient in with a robot, and the robot gets operated on by this kind of robot, but it's a robot-assisted surgery. It's this hand toggling a hand that's the size of a fingernail. So you can imagine that that ability to move in miniature has accentuated. But it's not just the hands. It's what is that robot hand, or what is that surgical hand carrying? A knife. But is the knife the same? And what are the eyes that are guiding this whole therapy? So my guided therapeutics program, which is the program I lead, the GTX program at UHN, takes imaging, a cone beam CT scan, for example, which is shown here, which was invented by a Canadian at Beaumont Hospital in 1999, David Jaffrey and Jeff Sirasdu, who now work in our program. We attracted them to UHN from the United States. And now we've put that on a Zigo robot, the same robot that is used in the car manufacturing industry. So we've loaded that cone beam CT scan on a Zigo robot, which allows us to take on-the-table, near real-time, on-the-table imaging. So we swing the robot in as we're operating, and it swings back so we can operate after the imaging has been taken. So we get a now, a minute by minute as necessary, idea of the 3D and 4D changes that occur as we operate. So this is an example of a patient with an osteosarcoma. That's a sarcoma, a bone sarcoma of the jaw, which is shown here. And I can use my near real-time on-the-table imaging to guide where I need to remove the jaw, where I need to make my cuts with regards to ensuring that I remove the tumor. And as importantly, we can auto-segment, computer auto-segment with our engineering staff. We can draw in the carotid artery, the tumor, in this case a tumor at the base of the brain, the optic nerve, and the pituitary and tumor target, so that we create essentially a virtual reality target as we're operating. So, in fact, this is our GTX dashboard, which allows us to create this imaging. You can see the tumor target, you can see the carotid artery, both in axial, which is this way, coronal, and sagittal planes. You can see where my instrument is, either a robot arm, so instead of using large incisions through the anterior face, we can stick a small robot arm through the nose without an incision and remove a tumor, because we have those small hands that allow us to take the tumor out, obviously guiding as we go, and updating with the Zigo robot as we go. And so this is a real-time view. This is an actual operating view. This is a virtual reality view that our engineers create, a so-called avatar view, which create no-fly zones for me, so that essentially I know where the carotid artery is, I know where the optic nerve is. You can see that the bone is covering those structures, but I know that behind that wall, behind that bone, by the avatar or virtual reality image, that where not to go. Where to go to get the tumor target, where not to go. And this concept of quality of life, preservation of structure, and quantity of life, making sure that we target the tumor, is absolutely essential. So that balance of quality and quantity of life. And that's true, whether or not we're talking about medical oncology, radiation oncology, or surgery. And this kind of technology has enabled us to use multiple minimal access approaches and be much more definitive or targeted with regards to our treatment. Whenever I put up this slide that has any element of blood, I notice people start to squirm around, and so I'll get right off it. But the concept of bringing technology together, a sum that's greater than its parts. I mean, I talked about cone beam CT, but we have other optical imaging. We can get tumors to fluoresce. Surgical tool tracking, preoperative imaging and CT and MRI, and merging those. I got the 5-minute warning. It's like the Raptors. You're down 20, but you know you're gonna make it. But the concept of bringing all of this technology together so that the tumor target can be realized. The last segment is nanomedicine. So this is where we create novel contrast agents. And I'm very lucky that I work with a nanochemist, which we recruited from the Johns Hopkins Hospital, and he invented the Porphysome. In 2014, he was awarded the Canadian Cancer Society Most Innovative Development for the development of the Porphysome. And the Porphysome is basically a molecule from the chlorophyll molecule. So it's a natural molecule. It fluoresces. When it alight, it shines green. And yet when you heat it up, it destroys. When you heat it up, it absorbs so much energy it destroys. So it's what we call one of this new kind of molecules, which we call theranostic molecules. Therapeutic and diagnostic. Can be used to help diagnose and can be used for therapy. And we've harnessed the energy of this molecule to be used therapeutically. So I want to go back to Dracula. Who would have thought I would go back to Dracula? So Dracula probably had, I know it's a fictional story, but it's probably about a true character, meaning someone who had porphyria and could not be exposed to light. So he lived in the dark. And when he was exposed to light, he got skin lesions because the light would absorb, his skin would absorb the pigment in his skin would absorb the sun energy and it would destroy tissue. So he had to stay inside. People with porphyria, which is a known medical disease, stay inside. The porphysome essentially harnesses the energy of a natural pigment, allowing tumors to fluoresce, but to destroy locally. So we've taken the porphyria molecule and we've loaded manganese on it to be imaged with MRI scan or copper for PET scanning. We can use it to light it, to create photodynamic therapy to destroy cancers, photothermal therapy to destroy other cancers. In the case of prostate cancer, photodynamic therapy for oral cancer and thyroid cancer. And we're starting to use this molecule in preclinical models to destroy cancers without incisions. So in the thyroidectomy of the future, the prostatectomy of the future, for example, might be a 3 millimeter incision where I introduce a fiber optic cable after injection of a porphysome molecule which goes to the tumor, and we basically light up the tumor to see it, fluoresces, and to destroy it. And this is an example of, this is an example of exactly that, where the tumor is fluorescing, both locally, and where I can see where the regional lymph nodes have spread. So I can see that tumor. I can see where it is, I can remove it. I can see where it's spreading. I can remove lymph nodes where it's spread. And if I shine enough light, I can destroy it without surgery. I'm doing surgery here, but I can destroy it without surgery because that therapeutic part, if I light and allow that molecule to absorb enough light, it destroys the cancer. So that's cool. And that's stuff we're doing now, and that's why it's a Terry Fox Expanding Horizons grant, because it's on the horizon and we're expanding. So we're not sitting still. We're starting to bring new technologies. Nanoparticles. 1 minute. We're down 2, but we're going to win. And we're going to have a parade after. So the concept here is that we're bringing new technologies to bear. The eyes to see, fluoresce, CT guidance, cone beam CT scan, tracking. We're bringing the knife, not a scalpel, fiber optic laser to explode a fluorescent particle to destroy a cancer. And so that concept of creating, innovating, translating that to patient care, evaluating it because we're a research hospital, and educating others, if we do it better, to take it forth. And this is the mission of our Techna program: create, innovate, translate, evaluate, and educate. And this is the Cancer War of the Future that we built about 5 years ago, which basically brings all of those technologies. It's actually an operating room that's bigger than this room. That's how big. And for those who are surgeons here or been in an operating room, this would be an enormous operating room, and this is the team that I work with. So no longer is it a surgeon and a nurse and an anesthetist, but I have engineers and physicists and others, diagnostic imagers working together, scientists working together to impact care. So the best way to predict the future is to invent it. And I thank you so much. And if there are any questions, happy to answer. And that was a Cowie Leonard, the 4. Hit it on time. Any questions? Board them all. Yeah?
At Rice University, in Houston, at the Da Vinci Robotics.
Yeah.
Are you familiar with that?
Da Vinci Robotics is well known. So it's marketed in Canada by Banogue Medical. Very well known. It is really the standard robot system throughout the world. It has a monopoly, until recently had a monopoly on most of robotic surgery, and it's the robot, in fact, that all of our Ontario systems use. There are some new, and I have no stake in, I'm not doing any commercial here, but I have no stake in robotics. So, technology also needs to be measured. Robotic surgery in the province of Ontario is still being reviewed. It looks like, at least, and I'll use an example of prostate cancer surgery. The robotic surgery patient in Ontario will leave hospital 1 day earlier. The question of whether or not the increased expense of $3,500 per case to leave 1 day earlier makes a difference. So then we look at quality of life issues related to margins. For example, the margin rates for T2 prostate cancer resections in the province of Ontario done robotically are around 16% and non-robotically about 22%. But the most experienced robot surgeons are also the most experienced prostate surgeons. So there's a question of, is it experience or is it the robot? The most recent randomized prospective trial on robotic surgery, for example, for head and neck cancer came out last week and shows no difference between robot surgery and standard open surgery. Many of the randomized prospective trials comparing robot prostatectomies versus non-robotic prostatectomies, the differences are quite muted. It probably has an indication, but we don't know what patients they're best for. It is clear that for the gynecological patient that has a BMI, that's a heavy obese patient who needs a hysterectomy or other gynecological procedure, the robot is probably better. The jury is still out on robotic surgery. So new technology needs to be measured. So that concept of evaluate, which I mentioned on new technology, critical.
The robotic surgery, I think, also helps the doctor in terms of what performances. I had my prostate cancer removed by Dr. Neil Fleschner at
Sure.
UNH.
No, Neil, very well.
UHN. He explained to me also the fact that it's a long procedure, and if the doctor can become fatigued and can affect the quality of the surgery. Whereas where you're using robotic technology, the doctor is relaxed, more precise, and can actually do more surgeries in a day than he could if he didn't have this robotic.
Excellent point. So we've done some ergonomic analyses, workflow analyses on robotic surgery. Again, not very well published. Very good information, and Neil's an excellent colleague of mine. Know him well. So, we did some NASA developed workload determinations for astronauts doing high complex procedures in space, and we've adapted those to the robot surgeon that are measuring exactly that kind of information. So far, the data is actually muted between differences between robot surgery and non-robotic surgery. I think your comments are really good, and I think that's, again, a question that needs still to be measured. The ergonomic benefits, and perhaps really maybe we only know about whether there's a career lifespan difference, which we'll only know over courses of decades, between a robot and non-robot surgeon, i.e. you're able to sit down and toggle versus standing up, obviously at an operating table. Those comments are really important. Thanks.
Great, thank you so much, Jonathan. That's fantastic, thank you.